point, I obviously kind of let him know. And I said, I don't know if we have a thermometer in the house, but might want to run out and grab one and bring it back just in case I do have a fever, although I already had a pretty bad feeling that I definitely had a fever. And obviously, the thoughts start going through your head of, is this COVID? And if this is COVID, with my 64-year-old dad in the car with me for 15 hours, this may not be a good setup. So those thoughts are starting to run through your head. They brought the thermometer out, and my temperature at that time was somewhere between, 105 and, excuse me, 101.5 and 102. And that moment was pretty awful, because it really just confirmed, and I kind of knew this almost certainly had to be COVID, just based on, again, risk factors and, no real other thing that at this time of year I think would be giving me a fever. I was obviously a little bit concerned for myself and whatever the journey held for me, but already like, oh no, this is exactly what I wanted to avoid. The whole reason I was coming down to Alabama and getting out of Manhattan was to avoid my own chances of getting it, and then obviously the risk of passing it on. And I think that plan seems to have successfully backfired in spades. So at that point, I hadn't even, I was basically, quarantined, if you will. We got there pretty late. It's just my dad and my mom who live in their house. And we had to have kind of a tough conversation before I even came inside, essentially, of, you know, for my mother, my dad at that point already was exposed, but for my mother, it was, that decision when you have a family member. And unfortunately, for those of you in the webinar who either have had a family member you live with who either develops symptoms or will develop symptoms, you'll also have to kind of make that decision of, do you want to stay in the house with them, or do you just want to, is there a way you can go stay somewhere else, or the other person go stay somewhere else? And after kind of discussion, we decided that because we live in kind of a ranch style house with kind of a downstairs, it's closed off. I would just go downstairs and we would do our best to quarantine me. And then just in case my dad got it, although I was very concerned that he probably would eventually develop symptoms, he was going to quarantine in a separate room in the house upstairs and, stay away as much as possible from common spaces. But essentially, for my mother, so to speak, assume the risk of at least living on the same level with me quarantined downstairs. So that was really the setup at that point.
It's the first roughly 12 hours you got home.
Correct. I mean, literally, right as we were pulling in the driveway, checked the temperature and said, this is not good. Fortunately, again, at least we had a house where I could really, truly just wall off from both of them. And so for those of you that do live in a house where you can kind of wall someone off, and, folks ask me, how do you get food and this and that? They would literally just leave something outside the door. I would touch the internal, my side of the door, pick things up. And then whenever I was done, I could, leave it on the ground. Fortunately, we did have a box of gloves. So that therefore, literally whoever's going to come get the dirty stuff picks it up with gloves, rinses it, puts it in the dishwasher, and then take your gloves off, wash your hands. Obviously, be cognizant when you have the gloves on of try to touch as little as possible, like already have the sink running, if you will. So you don't have to touch the sink handle. You can literally have the dishwasher open, and trying to limit how many things you need to touch if you are trying to care for somebody with COVID, so that, literally you touch the stuff, you rinse it, you put it in the dishwasher, you take your gloves off, and then with a bare hand, you can wash your hands and then shut the sink, shut the dishwasher. That's a very safe plan, if you will. Takes a little bit of thought. And I think the big thing I realized from having it and watching folks try and, to my mother, try and not pick it up from either of us, eventually from either of us, is, just trying to be thoughtful about how do you limit how many times you have to interact with the person, and how do you limit how many things they touch. And then when you need to touch inevitably something that's a common space or a dish or whatever, how do you be thoughtful about limiting whatever you then need to touch afterwards?
And just, it sounds like it's a split or a ranch house.
Yeah. Yep. Exactly.
Okay. So you're able to be on that bottom floor
Yep.
all alone. And is there like a middle area, like a landing area where the stairs kind of split?
Yeah, that's exactly right. So there's just, there's a door from the stairs. And so that door is the barrier, and they don't pass that way, and I don't pass that way.
Okay. And your parents are at this point, you're upstairs, you're downstairs, and you're never coming up at this point.
That's correct. That's correct. And so fortunately that next day I was already pretty nervous about him. So my course, just to, Eric made it sound a little more dramatic than it was. I probably had 3 days of fever back to like 101, 101.5, those persistent headaches that I mentioned, and this fogginess, fatigue, and that went on. And then I've developed a very minimal dry cough But again, if my symptoms started Friday night, by Sunday I was feeling a little better than Saturday, but still having fevers, and then by Monday I was fever free. So I had 3-ish days of fever and feeling crummy, if you will. By Monday, my fevers were going away, and I kind of just started feeling a little better. By Tuesday, I knew I was already on the upswing, and so my course, fortunately, was obviously more than someone out there who is truly asymptomatic, which we know there's a lot of folks out there that are going to catch this thing and truly never skip a beat. I wasn't that benign, but my course was mild, no
Okay.
doubt.
Couple things. First of all, are you able to, let's do some logistics? Your camera's shaking a bit. Is there a way that you could back off from your camera without it
Yeah.
falling so it's not shaking when you're talking? Uh, so a couple of things. I'm going to try to integrate some questions. So, I've been doing this for 6 years. That this is a big deal when my parents are actually on the call right now. So first question, I'm going to give my mom rights here with the first question. I want to summarize your progression of symptoms. She wants to know your progression of symptoms. It sounds like fever, headache, cough.
Yep.
Anything else?
Nothing else significant. I mean, if you really press me, I mean, were my eyes running at all? Was I sneezing a little bit, perhaps? I mean, I've got seasonal allergies. My sneezing was no more. It wasn't enough to be noteworthy. Perhaps though a little bit of sneezing, but the main symptoms where I knew I felt off were the things you said. The big thing I want to say though about symptoms, Eric, is and this is kind of the theme of COVID, and it's not just for folks with mild course or more significant courses. It really is all around. Everyone's journey is going to look a little different, and the symptoms, the range of symptoms can be, all the things that I've already talked about. Plus, it can be losing your sense of smell and taste. Plus, it can be diarrhea, because we know that the ACE2 receptors, where the virus enters in the GI tract, and I've totally talked to certain folks where their first symptom is losing sense of smell and taste. Their first symptom is diarrhea, and then more things start happening. And so, unfortunately, talking to one person like me is going to give you one person's journey, but there is no blueprint or textbook case, if you will, of how exactly this virus can present. It's highly variable, which is part of the challenge.
Okay, I want to get into a little bit about symptom severity and how lousy you felt, but let's take a step back here. Day in, your dad starts feeling crappy. You guys don't know if you're positive yet for sure. So take us
Correct.
through when your father started feeling
Yep.
lousy, when you jumped in a car and got tested. So take us through
Yeah.
that.
So again, Friday night it started. Saturday he felt fine. Sunday is when he developed chills and a headache a little bit, but really chills, and had his first fever Sunday night. And at that point, obviously, I knew just I think my mom was still a little bit hopeful, but I knew that we were both. This was 100% COVID. And so fortunately, because he obviously works at UAB. Monday, we were able to arrange for testing, which had started at UAB with the nasal swabs.
University of Alabama, Birmingham, for these New
Correct.
Englanders have no idea what you're talking about.
Yeah, University of Alabama, Birmingham, go Blaze. And we both went down. We had the nasal swab. Again, a little pointer for folks out there that do need to, that eventually get tested with a nasal swab. And again, the nasal swab is the PCR test that looks for active virus as compared to the blood test, which would look for antibodies. But for that nasal swab that looks to see if you're actively infected in real time, unfortunately, as I learned, that test hurts. There's nothing pleasant about having a swab shoved into the back of your nose. I joked with the person who did it that I wasn't sure if that was a nasal swab or a brain biopsy, because it felt like they went all the way back there. But I would like to tell folks that if you do need a nasal swab and it doesn't hurt a little bit, it's probably not an adequate sample. The person doing it probably did not actually get to your nasopharyngeal space, and it may increase your odds of a false negative. And we know that right now the PCR test has probably got somewhere between 75 and 85% false negatives. So if you are getting the nasal swab, prepare for a little bit of discomfort, but discomfort should actually be reassuring to you that the swab is actually getting back into your nasopharyngeal space to be run correctly. So we were tested on Monday, Eric, and the results came back Tuesday that we were both positive. And again, by Tuesday, as I mentioned, I was starting to feel a little better and on the upswing. Unfortunately, that's about, my dad was starting to kind of start the downswing. And essentially that first week, just to consolidate it for him. So at that point, as he wasn't starting to feel very good, I kind of decided I needed to probably go in and check on him, even though I was obviously still, not quite 7 days out. I definitely wasn't, frankly symptomatic, but I was worried about him. And I think, it just made sense at that point to break my own quarantine internally in the house to go up to where he was staying to go start checking on him. And fortunately, the rest of that week, I'd say Tuesday, Wednesday, Thursday, Friday, he still was having fevers every night, was obviously becoming a little bit more fatigued, and the cough was starting to get a little more progressive. But it was really Saturday, which would be day 7 of his symptoms, when things really started turning a little bit worse. And what we know, one of the few things I'd say we're seeing a lot is that, day 7, week 1, so to speak, of symptoms for a lot of folks can be pretty mild. And for some folks, week 2 ends up being far worse than week 1 as the virus starts setting up shop in the lungs if it gets that far. And so on that Saturday, on day 7 for him, is when not only was he still having the fevers, but his cough really progressed from this initial dry cough with nothing really coming up to developing this deep, thick, as we would call in medicine, a purulent cough or bringing up phlegm. And it was clear that his trajectory said, well, how did he look Wednesday as compared to Saturday? Say he looks worse. And neither of us were really terribly concerned on Saturday, but it was a little bit unsettling that he wasn't getting better after 6 nights in a row of fever. And that is when really, by that point, I obviously was kind of moving fully off, again, kind of moving a little more freely upstairs and downstairs, obviously, to watch him. And I would say that Sunday, Monday, Tuesday, and Wednesday, so for him, days 8 through 12 there, were really the scary parts. And for those that did read his article on his own journey in the Washington Post about, the concerns he was having overnight about whether he'd, kind of, have to go to the hospital, that was really days 8 through 12 of the disease course. And for him in particular, and I think a lot of folks are having this as well, the symptoms were far worse at night. And fortunately, because one, we had a pulse oximeter at home, which Eric, we can talk more about in a little bit, but a pulse oximeter is something you can stick on your finger to actually get your blood oxygen, your saturation reading. Starting Saturday and all the way through Wednesday, I just basically started checking his pulse oximeter readings to understand whether the worse I was seeing him look, whether it was as the cough worsened, whether that was starting to compromise his breathing. And so essentially, in a weird way, kind of on that Sunday, Monday, Tuesday, and Wednesday, it was almost kind of, rounding on him, if you will, or, checking in on him every, 4 to 6 hours, checking that pulse oxygen level, making sure he was mentating or that his mind was working, making him get up and at least walk to the bathroom, make sure he wasn't short of breath. And really just did our best. Yeah, thank you for the picture of what a pulse oximeter looks like.
It's a highly produced show, Harry, highly produced.
Yeah, thank you for that. And fortunately, the oxygen levels did get very low. I mean, when I say, very low is extreme. Low to the point where on Wednesday, kind of on day 12 of his symptoms, it reached a point where I told him, and I even called the rest of my family and said, if this thing drops 1 more percentage point, I'm taking him to the hospital.
What were the numbers there, just for the?
Yeah, so he pushed as low as 90%, which again, normal's 100, or some folks may run at 98 or 99.
Well, that picture, that person's sort of normal, 96.
That person's 96%. That's not a problem. And again, that number, 96, maybe 97 or 98 if you leave it on for a few seconds. But anything above 92 is definitely okay. 91, 90 for someone who's normal is when I'm saying you're really starting to push the lower bounds of, what would be normal. And then the real concern is if he drops to 89 or 88, it's not that he's going to crump out immediately. It's not like it's, if you live at 88 or 89 for a few hours or whatnot, you're in harm's way. The real challenge is, does this mean we're about to really start dropping? And again, that's the next concerning part about COVID. And the scary thing is that, once you start dropping and once you see that number, and for him, normal for him is whatever, 97, 98. And then it kind of goes down to 95, 94 when I'm checking on him. Then it's 93, 92. And you start saying, oh no, this is like, when does it end? When is the nadir? And fortunately for him, it really never dropped below 90. But that's when it was like, if it goes anymore, I don't know how much lower it's going to go, Eric. And that's the scary part. When everybody talks about the fear of COVID, it really is a scary time if it's you or your loved one, because you don't have the foresight to know where the bottom drops out. And we were very fortunate that 90 was really as low as he dropped. And then finally on day 14, so that Friday, He finally made it through an entire day with no fevers. The oxygen levels started slowly creeping up. And by that Monday, so probably by day 16, I'd say, of his symptom course is when I'd say I was comfortable that he turned the corner and was probably through it. And so that's,
couple of follow-ups there, right? So I got some, and by the way, folks, if you want to jump in the Q&A module, if you joined us late and unzoom, for most people should be at the bottom of the screen. If you don't see it, just hover over your Zoom interface and you should be able to see a Q&A little icon and click in there. I've got some questions myself and a few that came in. So first of all, when during the day did his oxygen levels go up? And when we're talking about that rock bottom number where you were one percentage off from taking him to the hospital, that was always at night, right?
The oxygen levels, unfortunately, were more consistent. I mean, I think it was the fevers and him just feeling lousy that seemed to be more night based. So basically, the general pattern was, middle of the day, from 9 a.m. until 4 p.m.
Mm-hmm.
If you went and just looked at him, when you just kind of go look at him, he looks okay. He's sitting up. He's looking okay. He's looking not ill appearing. His oxygen levels don't really change because that cough isn't bimodal. That cough and the thickness and the injury to his lung is consistent. And then really it was pretty predictable, somewhere between 4 and 6 o'clock every single day. When I'd go check on him, say, has it started? And it is that feeling of chills, that feeling that the fever is coming back on. And predictably for 13 straight days, somewhere between 4 and 6, he'd go, yep, it's starting again. And, that would really start off I think for both of us, you'll see how he said in his article, essentially for both of us, it was, let's just get to morning. And we know that night's going to be no fun. And let's hope that nothing serious happens. Again, I was fortunate that I had that pulse oximeter and could just honestly come and, throw it on his finger as much as I wanted to, so to speak.
Should everyone, we have about 200 people watching right now. Should everyone try to get one of these? I mean, is that an important sort of measurement tool to determine if we get sick, when we should go to the hospital? Or
so as you can imagine, from what I understand, they're in high demand right now because a lot of folks do want to have one in reserve. You would want to feel comfortable, using it and feeling like, you can read that number. We'll talk about it, Eric, when we get to what it's like treating folks in the hospital. But we'll get to how I actually think a pulse oximeter can be really helpful in getting folks home who are improving. That we need to free up beds, and if you're in a hospital where beds are precious, a pulse oximeter, having one at home can be incredibly helpful. So yes is the short answer, assuming you can find one and assuming that you have it's not hard. You literally just put on your finger and you get that nice reading. But you would have to have the confidence that you or a family member wanted to man, that's going to make you less stressed as opposed to more stressed. And obviously that's something that each person or family has to decide. But it can be incredibly helpful because that is the scary number, or what gets you into trouble, is when the virus reaches a point where you're no longer able to adequately oxygenate yourself.
So when you held out on me when we were doing our prep call, I heard your dad last night talk about you guys actually did try to do some treatment.
Yep.
And so why don't you take everyone through what he did, what we gave him, and if you do it again, if you had to do it all over again. And then I want to transition to how we kept mom safe.
Yeah. So so remember, folks, this was a month ago. This was probably literally, the March 16th, 17th of his symptoms. And so we know a little bit more now, not much more, unfortunately. And we can talk about that later, Eric, if you want. But back then we knew even less, shall we say. And our strategy around treatment was to essentially get the phone out and start dialing up, phone a friends to folks in Seattle that had a little more experience with this, the infectious disease doctors, my contacts or colleagues both in New York and Louisiana, and some of his colleagues up at the NIH, just to try and get everyone's anecdotal experience. And again, you're probably going to hear that word all the time now in articles and in interviews, and you're going to hear me mention it probably 5 more times today when we talk about things. Anecdotal simply means we're making decisions based off of one-off stories of, oh, when I did this, I saw it work, and it worked really well for like 4 patients or this and that. That is anecdotal evidence, meaning it's not evidence-based. And so we basically took anecdotal opinion from a variety of folks, and his preference, because it was really kind of, it was his choice, if you will, was to go ahead and take hydroxychloroquine and azithromycin starting on that Saturday or Sunday. I can't remember the day, but remember that day, I did kind of that turning point where it was clear that things were getting worse and not better on about day 7. And so he chose to do that. He took it for, I think the standard 5-day course. He said last night, and I actually had never heard him say this, but I think in hindsight, he said he regrets doing it. I'm not sure. I know for sure he regrets taking both of them because, and we knew this when he took both, and he assumed the risk. The challenge with that combination, when you take hydroxychloroquine and azithromycin at the same time, is that can lead to cardiac electrical abnormalities. And if that happens to you, you may actually just die of sudden cardiac death if your heart goes into a fatal arrhythmia. And so,
and that's not good, right?
Yeah, yes, that's correct, Eric. Even you're ready for your medical license.
I
I think you're ready. I've trained you well.
Yeah.
Yeah. So the thing is that if you're going to take both of those together, and you're not going to do it in a monitored setting, and again, although I did my best to run a hospital at home, I did not have telemetry on the guy or was not checking EKGs daily. You're assuming some amount to a good amount of risk that you're going to create a new problem, like go into a fatal arrhythmia, and you're doing it for 2 treatments that actually aren't evidence-based. And so I think that's what I think in hindsight, he probably means by saying he kind of regrets it. But I can tell you that when you're in the moment, and we can talk about this because it's the same moment I felt when I was up the street at the hospital, is when you're the one who doesn't feel good, or you're taking care and you're responsible as the physician for folks who aren't feeling well and who look worse. It's a very helpless feeling to do nothing. It's very helpless to say, I know you're worse today, and I'm not sure how much worse this is going to get, but I'm worried. And in his case, I'm worried about taking you to the hospital, and I'm worried about that oxygen number getting lower and lower. And once it starts dropping, I think the scary part is he and I both knew enough to know that once that thing does start going down, things you never want to think about, like having to go on a breathing machine and a ventilator, so saying, oh my, like what does that look like? And so, when you have those thoughts running through your mind, or you're in a hospital and you're talking to families and you're talking to patients, and they say, what can you do for this? Because, I'm worried about my loved one. And you say, I have no treatment at all that's proven. Sometimes folks reach into anecdotal medicine and say, you know what, give me the hydroxychloroquine, give me the azithromycin, even if there's not great evidence, give me whatever, might work.
Did you do anything for the fever?
Yeah, I mean, traditional kind of analgesics, Tylenol, Tylenol is I'd recommend folks, assuming you can tolerate Tylenol, to do Tylenol. If you're still really febrile, really having a fever and spiking through Tylenol, there's obviously a lot of debate, Eric, about whether NSAIDs or ibuprofen, Advil, does that make the disease worse? Does that facilitate, does that lead to worse outcomes? We don't know. Like a lot of things, we don't know. My personal advice would be, assuming you can take Tylenol and it's doing the trick, stick with Tylenol. If you're feeling horrible and your fever is 103 despite Tylenol, your options are to basically feel terrible, or perhaps at least try a dose. But I would definitely do everything possible to do Tylenol and avoid the Advil and ibuprofen, not so much because of the virus, because I mean, it's just unclear whether it makes the virus work. But as we all know, those drugs can cause problems with your kidneys, and they can cause stomach bleeds and all kinds of other things. So again, limit your risk and take Tylenol when possible.
Okay. There's a bunch of I want to knock off some of these clinical questions that are still outstanding, a bunch of them coming through the queue. So I'm going to go off script here and grab.
Sure.
Did you mention when you started that drug combo, what day in the evolution of his disease?
Day 7.
Day 7. Okay. Elevated heart rate as a possibility due to the release of histamines to fight the infection. Can you please comment on this?
Haven't heard that one before. You stumped me. I've heard a lot of questions these days. I couldn't comment on it. I haven't heard that, is all I can say.
So you stumped him. All right, great. What about shortness of breath with the lower saturation? Did you notice that when his numbers were lower? Was he shortness?
No, fortunately not. And that would have trumped the number. And again, when I say shortness of breath, again, because I can, I was essentially counting his respiratory rate or seeing how many breaths he was taking a minute. And obviously asking him, do you feel short of breath? Do you feel like you're gasping? He was, and so one, you can kind of like look at someone. Two, you can judge their respiratory rate. And again, depending on how badly you really don't want to take your loved one in the hospital, which I really did not want to do unless absolutely necessary, try to do everything I could at home, looking at his respiratory rate or how many breaths he's taking a minute, looking at that oxygen number. And then I would ambulate him. And he was ambulating, walk him, meaning like get up and walk. And, it didn't have to go far, just walk to the bathroom, walk around, the bed or whatever, and look for signs of shortness of breath. And what I mean by that is if somebody can't walk without stopping to, take a break, put their hand down from the bed to the bathroom, or, a reasonable distance that they should be able to do, you should be very concerned. That is an indication that I don't care what the number is anymore. You need to go to the hospital. Fortunately, he never, although his number got to that low level that got me concerned, he never was short of breath, air hungry, unable to, walk around without, becoming short of breath.
What about, did your dad suffer any lung damage from going through the disease? Do we know if patients are suffering through lung damage? And if so, is it permanent or will it heal?
When I say there's a lot, of course there's damage, there's damage to the lung. And remember, it's probably not the virus that's causing the damage. The virus starts and enters your nose, your mouth, it gets into your airway, through your eyes or wherever. And then it wants to, replicate, and eventually its goal is to get into the lung, or it gets into whatever tissue it can. But this one seems to, be really interested in trying to enter through these ACE2 receptors, which line the lung. And that's why we're seeing it enter the lung at such a high rate. And once it's in there, what happens is that virus starts getting activity or getting interest or attention from your body, from your immune system appropriately. And one thing that's really unfortunate about coronavirus that's making it, I think, really hard is that it's taking our immune system, because we've never seen the virus before. It's a novel pathogen. The immune system may not figure it out on day one that there's trouble in paradise, or there's a pathogen that's invaded. And that's why, folks can kind of walk around for a few days and feel totally fine, is that eventually your immune system kicks in and starts going and trying to neutralize that pathogen. And in order to do that, especially when it's in its lung, it is going to cause some collateral damage. It's going to cause inflammation. That's going to lead to kind of leakiness in the lung, and there'll be a little bit of fluid buildup. There's all that activity that has to happen to neutralize the virus, which now at his point was in various elements of his lung, is going to cause fluid and irritation and the inability to oxygenate. And then obviously for him, fortunately, the spread stopped before so much of his lung was compromised that it caused him to become short of breath or that oxygen number to dip. The concern would have been for other folks where they're not as fortunate, that virus takes over all their lung. And so it really was, the inflammatory response that's causing all of that damage and mucus. Whether it lasts forever, we don't know, Eric. I mean, again, the thing's only been around since December, so I can't even tell you. Nobody can tell you how somebody's lungs look in a year, because no one's had it that long. As best we know, we don't think that it causes permanent lung damage. I certainly hope not at this point, or else that would be unfortunate. But we just don't know.
Let's talk about keeping your mom safe. So can you talk a little bit about when you mentioned when you were sick, what you did to isolate both your parents? Now your dad's sick. So one, what did you do there? And then when you started becoming the caregiver, even though you were fairly symptomatic yourself, what were you doing to keep your mom safe? And then when did you feel like it was safe to be closer to her?
I'm going to tell you what we did, and then I'll tell you maybe what's more ideal state. So again, ideally for us, if my dad hadn't been infected, and you can just quarantine one person, that's a really good setup. And so, again, if you have a door or some kind of physical space and one person, or the one person can be on one side and everybody else on the other, I think you're in good shape. And really just do the things we talked about, which is limit, try and batch, if you will, how many times you even need to cross that barrier. Figure out how you can leave things at a doorstop, whether it's an indoor door or an outdoor door. Get creative. And then if you do have to touch or, whatnot, things that that other person who's quarantine's touch, uh, your options are to wear gloves and do all the things we already talked about. If you're not as fortunate to have gloves, perhaps you would just take, a paper towel or something, or a tissue or some kind of blocker, a rag, and pick things up with a rag or, whatever, and, or a paper towel, and still, do what you got to do. And then obviously wash your hands. You do have to really get thoughtful about, if I'm picking this up and I need to then touch that, how can I go ahead and prepare in advance and have the trash can open, or going to have the dishwasher open? I think small things like that are going to make your life easier. Inevitably, you're going to screw up, and you're going to, have you're going to have contaminated gloves or whatnot, and then you are going to say, "Oh, I got to touch the trash can." Not a problem. Open the trash can, throw things away. When you take your gloves off, get your wipe or your spray or whatever disinfectant you have, and spray down the handle or spray down the doorknob. It's not a big deal. You do need to be aware and you need to be thoughtful, but the more you can quarantine, the better. In our particular case, once he had it and was upstairs, and I was going in there every, few hours, um, quarantine, for my mom, unfortunately, kind of took a back seat. Or, we did our best, but I'll be honest, somewhere in that second week, I probably started deprioritizing that to some extent because I was pretty worried about him. Um, and, most likely, to be honest, again, she hasn't been tested. It's likely at some point my mom caught it, just to be honest. She did lose her sense of smell at some point. Who knows if, I have to think that it was probably coronavirus. Again, she was still living in a household with folks who were infected. It's very possible, no matter how many precautions you take, because this thing can be aerosolized a little bit, that you're at high risk living in the house. We at that time were less masks a month ago. We're not really something people talked about in mainstream. Obviously today it's a little different, and that shows you how much things change in a month. In hindsight, we should have probably just had a mask on him at all times, a mask on me. We didn't do that, but we should have.
How long does it until you were probably clear and sort of not contagious anymore? Did you have a sense of that? And what's your respiratory function right now?
Yeah. So, look, I'm just going to tell you what the CDC says about healthcare workers returning to work, which, to me is, if we're letting folks, if the CDC feels comfortable letting someone back in to be around patients and staff, then the CDC hopefully feels pretty good that person is not infectious, especially, again, if we're all wearing masks now and taking hand hygiene seriously and all that. And so the rules for that, Eric, are either 7 days after your symptoms start, or 3 days after your symptoms go away, whichever is later. So what to translate that, at minimum 7 days after your symptoms start. So for me, if my symptoms started Friday, I should wait at least until the next Friday, until really, leaving the house. And I definitely did not leave the house. Let me be clear. When I say I broke quarantine, I broke it, meaning that barrier from downstairs, upstairs. None of us, of the three of us, ever left the house, including my mom. And that was part of that agreement she had to have, is you've got to assume that you have it, or that you may be contagious any day because of that incubation period. And so, got the internal quarantine, not the external, just to clarify that for folks. But 7 days, or if your symptoms are still going on at day 7, then at least 3 days of being symptom free, whatever's longer.
Okay. And what about your respiratory function right now as we sit here about a month out?
I feel great. I would say 100%.
Because your dad mentioned last night he's still probably not 100%.
Yeah, and I wouldn't say that my respiratory function was 100% even 2 weeks ago. It was, to quote him last night, I was probably 98.5 2 weeks ago. So hopefully 2 weeks from now I'll be able to knock that to 100. And I remember when I talked to him when I come back to New York, once he was better, and just kind of asking him remotely, like, how do you feel? And he said, when he really exerted himself for the first time, and it wasn't major exertion, it was, I think he walked to get the mail or something, so further than usual, walked around, I think, the back to, exerted himself to some extent, more than walking from the bedroom to the kitchen and whatnot. And he said, like, wow, like that was a little harder than it should have been. And so that was, day 20, let's say, after symptoms. And now he's on day 30 and he's back to 98.5. So you're not, even once your scary symptoms go away and you've turned the corner, expect to feel,
Beat up.
to be deconditioned for another week or so.
All right, let's kind of start transitioning out of the patient experience with a
Sure.
couple of sort of takeaways. What would be what would have been the number one process to have in place if you knew then what you know now?
Hmm. Um, I think making sure that, assuming if you live in a house with a lot of folks where you really do want to try and not have folks get it, is have a plan in place. Planning is always a good idea. So in case anyone in your household develops symptoms, say, okay, first things first, somebody spikes that fever, like what happened to me that Friday night. I can tell you right now, the instinct is to panic. When I say I panicked, I was internally panicked more because I was worried about that car ride. But it's scary, and it's okay to say, "Uh-oh, I may have it or whatnot." Have a plan. You don't want to have to do your critical thinking in that moment in the run of, "Oh no, what were you just what were you touching?" So have a plan in place of, if somebody develops symptoms, we're going to do this, whatever this is based on your house and your setup. And so I'd say have a plan. You know, surely by now everyone has some amount of cleaning supplies, whether those are wipes or sprays or whatnot. If you can have some gloves around, probably makes your life a little easier. If you can have some masks around, probably makes your life a little easier. And then, Eric, it's really up to the individual about whether you want to have a pulse oximeter in your house, or maybe just to be more practical, spend your time while in your planning phase to say, does anybody in my community or in my network already have one? And would they be willing to lend it to me if I needed it? Since again, hopefully for most folks, you don't end up needing it, but perhaps thinking about that in hindsight would be good.
Anything that you would have done completely differently? I
Um,
guess the medication, right?
yeah, I definitely, I would not have taken both of them. I felt, and yeah, so I think the medications we definitely not have done both of them in hindsight.
Okay. And I know the answer to, well, I know your answer to this, but so folks know, because it's coming in, can you now, we're getting ready, you're going to head back to New York City. Okay. I know you're in New York City as we sit here, but I'm just
Yep.
painting the picture. You're getting better. Your dad's doing fine. It's time to come back to New York City and start treating patients where the hospital's pretty much going to be 100% COVID patients. Can you catch it again?
Well, Eric, like everything, we don't know with 100% certainty. So don't believe anybody 100%. I'll tell you as much as I know now, but recognize that just as we learn new things every day, we're going to learn a lot more about that specific question in the next month or two as we start doing more antibody testing and looking at how long immunity lasts. So with that caveat, I think so. And when I say I think so is assuming that when you are infected, your immune system generates a strong antibody response, then I think that if you have those antibodies floating around in your plasma after your infection, then your risk of that pathogen being able to get back inside your body and set up shop, if you will, kind of like we talked about, be able to replicate, you know, ad nauseum with, as much as it wants before your immune system does anything. That's just not, the chances of that happening again are very unlikely, because now your immune system has antibodies, and the minute it sees that pathogen, it's going to start neutralizing it on day one. And so the risk of that pathogen basically spending 5 days setting up shop and spreading in your body is much less likely. Now, I know there are reports of, people send them to me frequently, like, oh, this person got reinfected. This person got it a second time. You know, Again, no one can say with confidence, not me or anyone else. But my questions that I always have on these articles is, well, do we know that when this person got retested with another swab, that they ever actually cleared the first infection? Again, how long can your nasal swab remain positive from that initial infection? Who knows? Certainly well past 14 days. And at least, I've seen one data set that says it might even last potentially up to 37 days where you may test positive. Now, again, I'm not saying that that's absolutely true, but these are questions to think about when you're reading off that one-off report from a news article that, somebody says they're reinfected. But the second thing is that it's also important to think about that person who got reinfected. Do we know with confidence that they ever generated a great antibody response? Because remember, Eric, it's possible that you test positive. Just because you tested positive doesn't guarantee that your immune system created those antibodies to a strong level. And so really when I'll be concerned, or when I'll say, uh-oh, you definitely can catch this again and it can be very bad, is if somebody who has documented antibodies at a high level catches it again within 3 to 6 months as a new infection, which that has definitely not happened. So nobody knows, but again, both from a physiologic perspective and as well as anecdotally, there are plenty of healthcare workers like me, especially in New York City, that have already gotten this, that are basically back exposing themselves both in the hospital but in living. And I've yet to see somebody with documented antibodies, have recurrence of severe disease.
Okay. I want to transition to New York City now, get you back to the hospital, Langone Medical Center, downtown New York City, those of you familiar with it. And Harry's going to love me for showing this. And you're going to paint a picture for us on what it's like being there and just a day in the life now of a treating provider. Let me see if this comes up right. There we go. Is that you?
Oh, God.
Yeah,
Yeah.
here you go. Now, listen, okay, while we have this great photo of you, I want to pause for a moment because I'm looking at the time. Those of you who are new to us, you're going to get an email from me, another one, I'm sorry, any minute now, asking for your feedback. It is a survey that takes 3 minutes maybe to take. We've been doing this for 5 years. We have the data down, and it's really important. We never charge for you to attend these, but we still know an hour of your time is incredibly valuable, and we don't take that for granted. It's a privilege to have you here, and we want to earn that right every month. And to do that, we really want to understand the topics that are most important to you and how we can improve. And so we use this feedback form every month. We look at every response, and it drives everything we do in the future. So I ask you the favor of taking a couple of minutes to provide your honest feedback. It's mostly multiple choice, and when it's not, it's typically an option. It's optional to answer. So it's pretty light, and you could do it even before you get off the call today. Also, I just want to make a little bit of a commercial announcement, which I rarely do, but it's getting rare times. If you're an organization that sells into payers or provider organizations, you need to come up with some unique ways now to sort of market and sell your services. What we typically do, there's no sponsor today, but I typically fund what we do through corporate sponsorship. So if you're looking to showcase your thought leadership, your subject matter expertise, provide and produce engaging content for your market and increase your business development leads, I encourage you to contact me, contact the team. In fact, Kim Grass, who's our Director of Partnerships and Operations, she will be reaching out to many of you and just to explore if you want to have a very preliminary conversation with me, no pressure, talking about what you're trying to do to move your business forward in the future and how maybe we could partner in a way that makes sense for both organizations. So if it's not of interest to you, just tell Kim not interested. She won't bother you again. It's a soft sell. And if you are interested, we'd love to talk to you. Harry's company, Roster Health, they're our past sponsor. We do a pretty good job integrating your expertise into our content. Final announcement, and then we're going to get back to Harry and what it's like in New York City. Next week, we're actually hosting a kind of unique, another kind of unique, but different kind of unique special networking roundtable for those who work at a payer, a health insurance company, employer, someone that pays for their health insurance, self-insured, or a provider organization. It's going to be April 22nd, next week at 11:30 a.m. And it's meant to be a two-way discussion. So we're going to cover the topic of how virtual is going to be a critical part of care delivery moving forward. It's going to be limited to 20 individuals. We're going to break you into 2 or 3 parallel roundtables. We'll have a facilitator for you at each table, and you will have a two-way discussion with your colleagues around the topic. We'll send you questions ahead of time. And unlike today, where you're sort of sitting in, virtual, anonymity, next week you'll be on camera like we are right now, like Carrie and me are, and you will be able to have a discussion with your colleagues. It's a great way to learn from your peers across the country, as well as meet some interesting folks. So we're going to try that out next week on the 22nd. If you take the survey, you could sign up for it, or just email me directly at eglazer@sharedpurposeconnect.com. All right, that's it for announcements. Harry, take us through you come to New York City. What is it like walking into the medical center for the first time? Paint a picture for us.
Yeah, and just so everybody knows, with my kind of full-time job of running roster, I only go in the hospital, I don't know, once every 2 months or so, usually on weekends. Last time I'd been there was the week of Christmas, so it'd been a few months, obviously pre-COVID times. And the first thing I noticed when I got in was how empty the lobby and the elevators were. There was nobody there, which is very bizarre, especially for a Thursday morning at 7:45 a.m. and no line, no one waiting to get on an elevator is a little bit surprising. So clearly things were not normal. And when I got upstairs, I knew what floor I was on. I knew my team. I really didn't know whether I was on a COVID team or a non-COVID team. I just knew they needed my help or they needed extra staff. And my resident was there, and I said, "Well, are we treating COVID patients, or are these like the non-COVID medicine patients?" And she kind of looked at me and said, "Of course your team is a COVID team. Every team is a COVID team." And I think, Eric, that's when it hit me that there was no such thing anymore at NYU. And I think for many of the hospitals in the city and those in the surrounding areas, that the entire hospital had become a COVID hospital. And similarly, every doctor became a COVID doctor. And, my team had, you know, we're had residents from psychiatry and physical medicine and rehabilitation. And, on the other team, there were plastic surgeons and, hematology oncologists, outpatient docs that hadn't done, inpatient medicine in, decades. It truly was pulling from all hands on deck, which was obviously really great to see. And in terms of just kind of the spirit of the healthcare team. But it really was like, wow, this is everybody here has COVID. And so then from there, obviously, it actually became, since I was on the floor, meaning none of our patients needed to be on a ventilator. All of them were on some level of oxygen. If we were able to get folks off oxygen and walk them and prove that that oxygen level didn't drop when we walked them, we're able to get them home. And so everybody's on some level of oxygen. No one's on a ventilator. And so fortunately, again, I say all that to say that my experience and what you're going to hear from me, again, only represents what I saw taking care of, I guess, lower acuity patients that weren't in an ICU on a ventilator and one hospital in New York, knowing that all hospitals were kind of at different places with their census or whatnot. But essentially, the provision of care, Eric, is actually fairly similar. Where the big differences were, I tried with my team to limit how many folks would needed to go in the room. I mean, not only because of the infection risk, but also to try and conserve PPE or personal protective equipment, the number of gowns. You can see in the picture, you reuse your face shield, you reuse your N95 mask until they're soiled. But generally, most of us can make it through pretty good reusing those. But the gowns that you take on and off and your gloves, it's very hard to we're not reusing those as you go room to room. And so not only is there a PPE issue, but we're trying to limit the number of folks who go in the room. So whereas usually we would round as a team, myself, my residents, sometimes the nurses would come in so we could all hear the plan. We're going in individually, and honestly for my team, because I'd already had COVID and some of them weren't sure if they had it or obviously wanted to minimize their exposure. I went and saw all the patients myself and kind of said, look, I'm going to see them. So you don't need to really go in the room unless you're welcome to if you want to for patient care, if there's an emergency and I'm not around. But let's limit how many people go in there for right now, and just obviously everybody needs to be seen, but we don't need to unnecessarily put people in harm's way. So that was a lot different. And then when you go in the room, the biggest difference is that there's no one at the bedside. There's no family, because there's no guest allowed in the hospital. Fortunately, most patients when I'm rounding have one, if not multiple family members. And now you go in and the patient is obviously by themselves and has no family. And so what was different about rounds for me this time is for every patient, I would get if they had a cell phone, I would ask them, let's call somebody, whoever it is, let's give them the daily update. They could use FaceTime or phone call or whatever. If they didn't have a phone, I just use my own phone and we dial somebody and we give the clinical update. I'd examine them. I'd be looking at things just like my dad. How much oxygen are you on? What's your work of breathing? What happens when you get up to walk? Obviously, in these patients, we might have an x-ray to look at. We have labs to look at. So there's even more data to look at. And you're trying to give folks an idea of, is this person getting better? Is this person getting worse? And we had plenty of patients over the 4 days I was on, some that got a lot better and we sent home. and some that didn't get to do as well that we had to send to the ICU to get, to get more intensive care. And then some folks that chose to be comfort care that basically say, voluntarily, if I were to get so bad that I need an ICU or I need a breathing machine, I wouldn't even want that. At that point, convert me, make me comfortable. And we had a few of those as well. And so,
Is there anything that's changed in your messaging to patients since you suffered from the same illness? Has anything have you been able to communicate a little bit differently to the patients and the families, or?
the one thing that I could say with 100% confidence that maybe I wouldn't have, had I not seen my dad, is that, it's day 10 for them of their symptoms. And, you know, they're worried, is this ever going to end? Am I definitely going to get worse? And I could say with confidence, yes, there's a good, there's a chance, a very good chance we can get you better. And don't lose hope. Just because it's 10 days, this isn't the rest of your life. And I've seen people, I'm not gonna say plenty, I've seen people go longer than 10 days and actually look worse on day 11, worse on day 12, and end up doing fine. And so it was a lot easier for me to give that reassurance for folks that this isn't atypical to not be feeling better or still not be ready to leave the hospital after day 10 or 11. Maybe, you know, I'm not sure the patients loved it if I said, look, we're not through this, because they always want to say, well, when is this going to end? And you say, I don't know. We just have to take it day by day. But just because it's day 11 doesn't necessarily mean that you're going to end up in bad shape.
Now, actually, quick time check here. I know it's 4:00. We took a bunch of questions from you all. That's why we're running a little bit behind schedule. We're still going to get to everyone's questions, hopefully in the last half hour we have here, including ones that sort of relate back to when Harry was a patient. So I haven't forgotten about you. You keep them coming in, and I'm sort of categorizing them and trying to get them into the conversation here. Harry, you talked to me, the most challenging things as a provider at Langone. There was a couple of interesting examples you gave me the other day. So why don't you share with the group what are some of the things that are uniquely challenging that back in the old days, like 3 months ago, 2 months ago, you never would have thought of as being just an inherently challenging thing for you and your fellow healthcare workers?
Yeah. And let me take this opportunity to say that although the world was different for the physicians, the world looks tremendously different for nurses. And whereas physicians, we go in the room once or twice a day, nurses are constantly having to go in and out of the room. Patients need help going to the bathroom and they're on a wall oxygen. You got to take them off that and move them onto a portable oxygen machine, walk them to the bathroom, get them back in bed. They soil the bed. They have pain. They need help eating. The list goes on and on and on of somebody's got to go in the room to help patients do something. That's the daily existence for nurses. But in a COVID world, again, the effort to gown in and gown out, or as we say, don and doff this PPE, it wears on you, and it wears on you because it takes effort and it takes time and it's uncomfortable and all that. And of course, if you haven't already gotten COVID, again, one big difference for me than my other healthcare workers is I'm not going to say I'm not afraid of it. And obviously, I took all of the precautions. And let me be clear, I do not want this again. And I am taking all of the usual precautions and wore the same PPE as everyone else. And no one should be cavalier, whether you've gotten it or not, should say, I'm going to cut corners on trying to increase my risk. But compared to somebody who really hasn't gone through it at all, there's still a difference in fear or stress in trying to have to go in and expose yourself over and over and over, even if you have all the right PPE. And so nurses really are the backbone of COVID care. And I can't say enough good things about the NYU nurses and the ones I worked with. And the biggest thing that they have to do in the care, at least of floor patients, again, those that are not in the ICU, is everyone's on oxygen. And what we're trying to do is get people down to the least amount of oxygen possible. And Eric, I don't know if you have that picture of what the device looks like that hooks into a wall in a hospital, but as those of you will see, this is what the oxygen device looks like in a hospital. And to point it out, yep, that's yeah, that knob you're seeing that Eric is drilled into, that's the knob that determines how much oxygen you're flowing into someone's nose if they're on a nasal cannula or a mask. You can see numbers. Right now it's at 1. You can see 2, 3, 4, 5. Those are the amount of the liters of oxygen per minute that you're giving. 1 being, 0 being room air, or you don't need any oxygen. 1's a little bit, 2's a little more. Clearly 5's a lot more than 1. The goal that we want to do is try and get people from wherever they are down to 0 or down to room air. But the way you do that and the way you kind of watch people is you have to titrate it. So how do you do that? So the plan each day is, how do I help get you off oxygen? That's correct, Eric. The only way to change someone's oxygen levels is for somebody to go in there and physically turn that knob. And so when you come out and you say, wow, this person looks really good on 4 liters today, and their number's 97%, let's go down to 3 for the next couple hours and see what happens. Somebody's got to literally put on the gear, and it's usually our nurses, go in and turn it down to 3. And then, Eric, you can imagine what happens. Sometimes 30 minutes later, sometimes an hour later, the number drops. You say, the person's not ready. Go back to 4. And literally, this is a lot of the COVID floor work is somebody's got to go in and titrate that. And so one thing that the nurses and I talked a lot about is how, you can control your thermostat these days from an airplane. Why is it that, in order to titrate and literally move the oxygen dial, it still requires a human to go in and literally physically turn a knob? One thing that we kind of put our heads together, and I think, some folks are thinking about it up the street at NYU, is how do we remove that barrier so that we can not have to go in the room every single time just to literally turn a dial? And think about how much
the PPE costs are huge, right? I mean, every time you go in.
Gowns are becoming as scarce or as challenging to find as the masks and everything else, because the frequency, I mean, I'm going through, if I have 18 patients, I'm going through at minimum 18 gowns a day, but probably more. And so this is one hack, if you will, that I'd love to see. And again, I think hospitals just haven't ever thought about it because it's never really been an issue. Because usually, if you can just walk into a room and turn the dial and walk out, it's not very painful. Sure, you got to, use a little sanitizer or whatever, but not a big deal. In a COVID world, moving that dial, which we have to do for every patient, becomes a very big deal. The second thing, Eric, I'll say that kind of goes on that same line that I think is really innovative, and I can't even take credit for this. I was actually talking to one of our endocrinologists up the street. For those in the hospital that do have diabetes, we have to check their sugars, before every meal and see what their blood sugar is and perhaps give them some insulin. And how do we do that? Well, we do that usually with a finger stick glucometer. But in order to get someone's blood glucose from that finger stick, somebody, whether it's a nurse or a PCT or somebody on a person, has to go into every room 3 times a day, and usually at bedtime, so maybe 4 times a day, just to stick the finger to get a little bit of blood, so we know what the value is, so we can then dose the insulin or whatnot. Now, what one of our really smart endocrinologists at NYU, Steve Hodak, I was chatting with earlier, is doing is he's working with remote, not a remote, just a digital glucometer that at least can kind of stay plugged into someone's body, so that basically it can tell you outside the room what someone's sugar level is around the clock. It's not delivering insulin, but think about now if we can just put that, especially on our ICU patients who are not only more infectious but prone and whatnot, and for those in the ICU that are on an insulin drip where we've got to actually be checking that sugar every hour. Imagine if we don't have to go in the room and don and doff and get the finger and all that. So I think being really smart, the root theme here, Eric, is how do you limit the amount of times you need to go in the room, and how can you do more and more outside the patient room and minimize how many times you need to go in unless you absolutely need to. And both for PPE, for exposure risk, all of the above. There's so many things I think all of us have paid attention to now that we maybe haven't in the past. Said, boy, we really, going in the room isn't actually necessary if we can figure out a hack or a way around it. The next thing I think that was apparent on my side of the aisle, meaning trying to get folks home, since obviously my folks were getting better, we were trying to get them off oxygen and get them home. And again, knowing the bed crunch from 2 weeks ago when New York was really peaking and plateauing, beds are precious in every hospital, and they probably will be in your community too, as if and God forbid COVID comes to your community. There are a lot of patients, Eric, like we talked about. This thing can last a while. And as much as we would try to get people, the picture you showed had someone on 1 liter of oxygen, one measly little liter, not very much. But when we turn it down, they go down to an unsafe number. And maybe that number is unsafe just when they're at rest. Maybe it's unsafe. Maybe their number is fine when they're laying in bed. When we say, okay, walk to the bathroom and let's see what happens. And they get up to walk and that number goes down. We say, woof, I don't like that number, but you need to be on a little oxygen when you walk. What we realized is that a lot of our patients, not only are they itching to get out of the hospital because they've been away from their families, it's miserable being in the hospital. A lot of them have been there for a long time, but this barrier is actually that they're almost better. And we as the medical team feel really good that they're on the upswing. They've already nadered or, had their bottom moment. but we need a little bit of oxygen, maybe for a few more days to bridge them. The only reason I'm keeping them in the hospital is because they have this little oxygen requirement. And what we really worked hard on was working with our durable medical equipment partners, our DME partners, and again, a lot of teamwork between myself and our care managers and our social workers who are all excellent. Teamwork between our insurance partners that have to pay or authorize things like durable medical equipment and home oxygen tanks to go in the home. And my advice, and then obviously that pulse oximeter. So generally home oxygen, it does come with the tank and all that and the cannula, but they don't always come with that oximeter. And so if we don't know the number, it's very hard. I can teach someone how to use the tank. I can tell them the numbers, but if we don't know the number, it's going to be hard for them to manage it themselves. And so we spent a lot of time hacking around of how we could solve for these things. I think if I were a hospital out there that, is thinking about how we can be ready for COVID, just like the planning we've talked about on how can we limit how many times we have to enter the room for things that maybe we can monitor remotely or whatnot. Same concept of how can we already be prepared with our insurance partners in the community on auth for those home oxygen tanks, our durable medical equipment, the O2 providers, perhaps the suppliers of those pulse oximeters. How are we ready to go so that that's not a barrier to discharge, so that if everyone feels comfortable, the medical team, the patient, the family, and we all feel good about going home and that they can check that level and they know to come back if the number drops. Think about how much, we could have gotten folks out even faster and I think safely. And again, it's not like we're moving folks out, we're worried about crashing, but again, if you can monitor that oxygen level and you have a little bit of oxygen, and we think you're on the upswing, I'm really not doing anything differently for you sitting in a hospital bed than you could do at home. And so how do we do more to shift care to home and get folks out faster? Something I think is a really important idea that I think others in other communities may want to start thinking about.
All right. So this is what I'm going to do here, guys. We have a bunch of questions in the queue. I probably have close to 20. I want to get through as many as we can in the next 18 minutes. So
I'll be rapid fire on the answers. Eric.
Rapid fire. Let's see what we can do.
Just interrupt me if I'm going too long.
I'm going to so I have one of my producers, Rohit, wants me to, before I get into Q&A, to pause the recording and then restart it. So I just need to do that. I do it all here, right? All right. So we're good. All right. So let's talk about can a PUI and a confirmed COVID case stay in the same room? PUI, just for people that may not know that acronym, is person or patient under investigation.
Correct.
Okay. So can they stay in the same unit?
Can they stay in the same unit? I would say a unit is okay. I would not put them in the same room until if somebody's under investigation, you're not sure if they're positive or negative. You don't want to put that person, anyone who's not absolutely confirmed positive, I would not put in the same room as somebody who's a confirmed positive. But unit, I think is, if you need to, you need to. Ideally, your hospital can have a COVID unit and then all the other units aren't, but I think it's okay.
I've heard that if you suspect or know you have COVID-19, you should not take Tylenol.
I haven't heard that. Again, it doesn't mean there's a lot we don't know. I think that if you're having fevers and you're feeling lousy, you're going to want to probably take something, and your options are basically, Tylenol or one of those NSAIDs we talked about, like an Advil or an ibuprofen. I think, again, who knows what we'll know 3 months from now. I would err on the side of Tylenol over the ibuprofen and NSAIDs.
Mask question, and I'm sure everyone wants to know. Yeah. Which mask for which situation, your perspective, not the CDC's? Good luck with
that. So, look, I think, the big differentiator is there are N95 masks, which I'm sure, everyone's kind of heard of or whatnot. And those are that one I was in the picture on that healthcare workers are wearing. They have a really tight seal. It thinks, N95 means it thinks keeps 95% of particles out or whatnot. Most folks are not going to have easy access to N95 masks. If you're in a healthcare setting and you're taking care of COVID patients, you absolutely should be wearing an N95 mask. It's not really realistic if you're taking care of a COVID patient at home to expect to be wearing an N95 mask. And then beyond the N95 masks, like a surgical paper mask, a cloth masks, I don't know if I haven't seen any literature to say that one of those is better or different than the other. So I would say there's basically the delineation is there's the N95 masks and then there's everything else.
Okay. Uh, very good. So
And I guess in case the question was more about should people be wearing masks, the answer is to reduce everyone's risk. Yes. And it's not necessarily that wearing that paper mask is going to knock your chances to zero, but when you're walking or you're in the hospital or you're at home, not at home, but you're in the grocery store, you don't know if you're going to sneeze. I don't know if I'm going to sneeze. Sometimes they come on pretty fast. And, think about what you're doing if you're, if God forbid you are infectious and you didn't mean any harm, but you're walking around the grocery store or standing in line at CVS and a sneeze comes on and you sneeze and you do your best to but what a nightmare. And again, I think wearing a mask
let me jump in because I got a question that just came in.
Yeah.
There's a lot of conflicting information about the virus living in the air for 3 hours, etc. Do you have any data to suggest that this is true?
I don't have any data to suggest this is true, but I think that to me, again, can the virus be aerosolized since it's a respiratory, a droplet airborne, it's not a droplet virus. When you cough or sneeze, you're putting respiratory particles out into the world. No question, I think all of that particle, a lot of that particulate, if you're infected, is virus. And so, containing that to your own face would be advantageous in my opinion. Not 100%. It's still unfortunately going to probably leak out here and there. But, again, why not do the easy stuff if you're indoors? You're protecting yourself. You're also protecting someone else. You're also limiting the chance to touch your own face. I know they stink. I don't even like wearing one when I'm outside, but I do. Definitely when I'm indoors, and I do my best to wear it all the time when I'm, in ambient air. But when I'm indoors, I'm pretty intense about it.
Let me get back.
It's about others.
Remember, we're in rapid fire.
Yeah.
Let me go back to medication.
Yeah.
If ibuprofen is one that's dangerous to take, why is ibuprofen more dangerous than Tylenol?
So, like I said, there's no data to suggest that ibuprofen is worse for the virus right now. And again, we don't know. Maybe we'll learn more. There's anecdotal reports that ibuprofen may be worse. What I can say with confidence is that ibuprofen, forget COVID now, ibuprofen and NSAIDs, that class of medication, Motrin, ibuprofen, Advil, we know 100%, forget COVID, this was true pre-COVID, those medications can increase your chances of having kidney problems or bleeding problems, particularly in your stomach. And so particularly if you're at risk of those or you're older or you're having bad symptoms, to me, you want to do everything possible to prevent another problem from forming. So forget COVID, the last thing we want to do is unintentionally make your kidneys worse or cause a bleeding problem while you're also dealing with COVID. Tylenol generally is a safer medication that has less side effects. And so that's really the rationale on that.
All right. This is a dangerous one, but I'm sure everyone's thinking about it and wants to ask it. So I'm going to ask it for them. Disregarding politics, what are your thoughts on reopening the country?
I think I'm not going to give I don't have like a specific, like this is the day. Here are some things that I'd be looking for. One, every community is different. And so there is no reopening that makes sense where it says the whole country, it's a good idea, it's safe to reopen the whole country on this day. Every community, and even drilling down deeper than just a state level, every community is going to have unique factors that I can talk about that would make me more comfortable reopening. So what are those factors that I would be asking in my local community? I'd really be looking at what are my hospital census in my community? Basically, how full are my hospitals? What's the capacity if we were to reopen and see a resurgence of patients that we would have staff, beds, ventilators, medications? And I would want to feel really good that my community could absorb a rise in patients and that doesn't concern me and my local community. And again, that's something that looks very different in New York City than where you are in Boston, where everyone else is. But that's a really important determining factor, I think, that you need to be thoughtful of before you reopen. The second thing is, what are our local communities' testing capabilities? And right now, again, the thing we're doing mostly is those nasal swab testing, looking for active infection. Again, every community has different availability. I've heard horror stories from some folks saying, I cannot find a test still. I've heard horror stories saying, I get a test and I wait 5 days for it to come back. But I think a community being able to know that they have widespread testing available, ideally both the PCR nasal swab and the blood test look for antibodies, would tremendously influence my comfort level with reopening the economy. And then finally, Eric, it is understanding what setting in advance before we reopen in my community. I'm going ahead and deciding or working to kind of understand guardrails around what is it when I need to, what is the threshold where we need to put the brake back on or potentially go back into kind of a lockdown or whatnot. And I think what you're seeing in other countries and what I think you're going to see here is different communities are going to reopen. And then unfortunately, they may need to take a pause or go back into a lockdown if things do go up. And I think every community is going to, unfortunately, or fortunately, depending on how you want to look at it, because it's better than just everyone locked down forever. When we take the foot off the brake, they're likely, we should be prepared to see an insurgence probably 7 days later. So it's not going to happen in that first week. It'll be 7 days later. And just be prepared and have thresholds in place of what it would take to say we should really start tamping this down.
Harry Saag for mayor. All right, I got a couple more clinical questions. Let's see if we could rattle through them quickly. Would H2 blockers help slow any progression?
I haven't seen any data on it, but they can't hurt. So as far as I know, if you feel comfortable taking, H2 blockers, usually we're taking for like heartburn and things like that. I haven't seen any reliable data. I don't think they're generally harmful. So, if that makes you feel good.
We're gonna go into the hospital now. Would it make sense to have I think this goes to sort of when you're talking a little bit about those oxygen monitors and some of the information you're looking for. Would it make sense to have a monitor to be able to measure minute ventilation non-invasively on the non-intubated patients that could measure high worker breathing within the first 2 minutes of hyperventilation that could alarm into the nurse call as an early indicator and perhaps help to keep them off the vents, or to provide this monitor for home health care to monitor at home so early indicator to know if you need to go to the hospital?
Look, it would be a nice additional data point. I'm not saying there's no value if you can have a way to essentially, measure minute ventilation or, respiratory rate or whatnot. But to be honest, I don't sense, or again, all I really need is that oxygen level, and that's good enough. I don't think the need right now is to create a second or a third measure work of breathing, another metric for work of breathing. Honestly, if you could give me, if the next thing I'd ask for after the pulse ox is just give me a FaceTime of what the patient looks like, and I can actually just look at their work of breathing myself. But to me, the pulse oximeter, whether it's in the hospital or at home, and unfortunately, again, at NYU, we're able to put everyone on continuous pulse oximetry. So that number's, you look up the monitor anytime in the nursing station or the bedside, and you can see it. That's good enough for me. So I'm not seeing that personally as I'm not saying it'd be bad, but I don't think it would be a tremendously, change my ability to manage either at home or remotely.
What is your best guess to why the virus impacts some more than others?
Well, isn't that the $1 million question? That one should have gone to Fauci last night on C-SPAN. That one is if I knew that, I wouldn't be sitting here, Eric. I tell you that much. But I think that we're going to learn more about that, and I think that's a really important question. That again, one thing I've tried to explain to folks is we are getting smarter every day. And certainly, again, Eric, if all of us think back 1 month ago, and again, I've admitted some things that we wished we'd done differently. And I saw one of, I think somebody actually did, just message the panelists and had a great point that one other thing we've learned and that potentially you could do at home, but we're doing it more in the hospital is folks do oxygenate a little better on their stomachs when we prone them or put them on their stomachs as opposed to their back. It is things like that that we're going to learn as we go. And we have a really brilliant scientific community. And unfortunately, we probably were a little behind in kind of, getting our scientific community revved into this, but we're learning new things every day. If we give our scientific community another few months, we are, I do think, going to learn or be able to answer questions like why are certain people getting sicker? Why are certain people with similar risk factors not getting sick? Those are questions that I think are answerable, but they're not answerable today. And that's why I think the most important thing for all of us is the more time you buy. And again, unfortunately, many more people will get coronavirus, but getting it in August, we're going to know so much more about everything, all these questions we're taking, treatments, and what are the chances of getting sick, and what do I do on day 3 as opposed to day 9. If we were to have this conversation in August, Eric, it'd be a totally different conversation. And so that's what I think the other thing for folks to think about is taking more extreme actions now is also not only helping stop the spread, we're buying our really smart scientific community a lot more time to learn more about this so that if God forbid you do contract it, we're going to be a lot smarter about all these things.
Is the virus from what you're seeing in the hospital, is it affecting children the same way it affects adults?
Well, I only take care of adults, so I mean, I can't even speak to what was going on in the pediatric wing, so I can't speak to that, except to say that it doesn't appear that kids are nearly as symptomatic, severely develop severe symptoms. And again, I can't quote you. There probably are some case reports, so I'm not the right person to say whether there's any chance, but fortunately, generally speaking, it seems like kids are not developing severe symptoms at the rate adults are.
All right, looking, this just gives me an excuse to put this picture up. Looking, hang on for a second here, because I want to get the picture up there. Looking at the face mask shield setup, any advice how a dentist who has to wear lupus should wear a shield too? What's that word? How am I not reading that right? Is it lupus?
Oh, I'm not sure. I'm not. Lupus. You're making me think of, again. I think.
know,
Are you sure it's not a question about? Are you sure it's not a question about Plaquenil and hydroxychloroquine? Because that's what we use to treat lupus usually. Now, everyone knows hydroxychloroquine, which is interesting. But here's the thing: is that remember? So this is my setup, and this is the setup on a floor patient that's not intubated. I'm not doing a procedure. I'm not doing a surgery. I'm not trying to put a tube or a line into somebody.
Oh, wait a minute. It's loupes, the kind of glasses. Any advice on a dentist who has to wear
I see. Sorry.
and should wear a shield as well?
Yeah, I mean, look, I think you're going to have to play around with it. There are more aggressive get ups, if you will, and like what our anesthesiologists wear when they go in a room to intubate, what a surgeon would wear if they have to operate on a COVID patient. You will have to look around, and I can probably find out for you what they're doing. But that's just one setup, if you will, that at least does a good bit of protection for non-critically ill patients where you're not doing procedures.
All right, almost there. A couple more minutes to go. Remember, folks, please take that survey, because if you don't take it now, I'm going to be bothering you for the next few days, and you don't want more emails from me, that's for sure. Generally speaking, Harry, this is a question near and dear to my heart. Are telemedicine services well equipped or prepared to help treat patients virtually, hopefully mitigating the masses from rushing to an ER urgent care center? Are these services recommended? God, I can answer this. Go ahead.
Yes and no. And so, where we are and where we're good to go is, we have platforms, whether those are companies like you work for with Teladoc, or as we know, CMS and HHS now let you use FaceTime and Skype and Zoom. The world doesn't need another platform to conduct a video visit. So we're good on that. We're good on most physician practices. Again, even if a doctor is having to use their FaceTime app on their phone, doctors on the physician side and the practice side, maybe they're very new to telehealth, but they likely can figure out a way to, have their side ready to go. And for patients that are comfortable using digital health and telehealth, when they have the devices, they have Wi-Fi, they have broadband, they should be able to connect pretty freely with their medical team. Again, what you won't know from a virtual visit, where the limitations are for that population, is you won't know vital signs unless they happen to have some of those devices that we talked about. A lot of patients, again, you may want to know some of those metrics, those biometrics we talked about. And then beyond that, just for routine clinical care, which is also obviously moving to telehealth, a lot of patients, we do need labs, to be able to measure how someone's diabetes is doing, or this, that, and the other, or at see how your kidneys are doing if you're having on medications that may affect kidney function. And so we have to think about where telehealth, how much telehealth can do, and then where those gaps are, and then be prepared to help patients, as I like to say, execute the plan. Because I think creating the plan now, Eric, like if we were doing a telehealth visit, I could look at your stuff and say, all right, Eric, I want to change this medication. I want you to go get this lab. I want you to eat this diet, and I want you to check back in a month. The hard part is not me coming up with that plan. The hard part is for the next 30 days, you executing that plan. And so I think being thoughtful, not so much for patients that may have means and access to technology, but there's a lot of patients out there, particularly those that may, may have more social determinants of health, that have never used telehealth, may not have access to technology or devices, and maybe, again, are not used to, have never had to conduct care this way. And so thinking about how we make sure that everyone's able to get care and access care and then execute the plan, because that's going to be challenging no matter what income bracket you are, is I think really where, we as a healthcare industry need to be thinking. To me, this part, the video visit,
Wouldn't
good.
you agree though, taking that first step, if you have access, rather than rushing into a hospital, that's where you're going to get really sick if you don't have the virus. Let a doctor help take you through the questions, right?
Oh, absolutely. Sorry. So if the question were simply just you have symptoms, 100% use telehealth, 110%. And if you're not, again, if you don't have access to telehealth, call your physician's office before you just show up. Don't show up unannounced, because if you do need to be seen, which some patients are going to need to be seen, that way the clinic can be prepared, the nurses, the doctors can be wearing their N95, their face shields, essentially the stuff I'm wearing. So showing up unannounced is not a good idea. If you think you have symptoms, call your doctor, use telehealth, or at least give your physician's office a heads up. And most practices now have protocols on how they would take you in if you need to be seen.
Harry, thanks so much. Folks, I know I didn't get to we answered close to 40 questions. We didn't get through all of them. I apologize. We did the best we could. Huge round of applause, Harry, for giving us 90 minutes. You kept we still have 100 people on, so I can't believe you. A record event for time spent online by Shared Purpose Connect. So thank you very much for that. Really interesting stuff. Those of you, please take the survey. If you have additional questions for Harry that are really important to you, I'm sure I could get them to him. He would be kind enough to answer them.
Sure.
So through the survey or email me directly, I'm happy to. You can find me on
problem.
Twitter, Eric Glazer as well, or on LinkedIn. Incidentally, Harry, you're at Dr. Harry Saag, SAAG.
Yep.
On Twitter, Roster Health. Check out them. You could read all about Harry and what he's doing with community health workers, and you could reach out to him by Roster Health's website as well. Thanks so much, buddy. Really appreciate it.
Right. Thank you. Okay.
Take care.